Hi, my name is Joanna White-Oldham, and welcome to Chronic Visibility. Approximately 1 in 2 Americans suffers from some sort of chronic condition, and of those, 96% of those people suffer from an illness that is an invisible chronic illness, meaning that by the naked eye, they may appear to be completely healthy. This fact presents a series of challenges that are unlike any other for people who are ill, and as a patient, I'm here today to discuss those challenges with representatives from the Arthritis Foundation, the SLE Lupus Foundation, and with a rheumatologist, Dr. Mona Pervil. So just sit back, relax, grab a pen and paper, because there'll be lots of information that you'll be receiving here that I'm sure that you can benefit from, and stay tuned for more from Chronic Visibility. So we're here today with my rheumatologist, Dr. Mona Pervil. I thought it was necessary that we talk with Dr. Pervil. You know, we live in a day and age where people profess to be doing things and claim to have things and claim to do things. I'm a person who does and is what she is. And this lady has gotten me through a lot of things, and I just wanted to thank you for everything, Dr. Pervil.
Well, thank you, Joanna, and thank
welcome.
you, yes, this wonderful audience. Knowing Joanna has been such a pleasure. It's equally a pleasure and an honor to really be here today.
Yes.
I mean, doctor, patient.
Yes, yes, exactly.
You know, from the first day I met her, she was such this dynamic, inquisitive person, asking lots of questions and wanting to know everything on day one. And it is a pleasure to be sitting with you today.
And it's a pleasure to have you. So there's some things about you I don't know. And so I think I would like to know those things about you. And first of all, I know that how long have you been in practice, and what made you decide to be a rheumatologist of all of the things that you could have been?
You know, I've been 10 years in private practice. Immediately after residency, I went into rheumatology. As a resident, you know, during our residency years, we have to go to the different disciplines in medicine, and that usually guides us to what really we called for. And I didn't have that call as a child. I knew I always wanted to be a physician, and but it didn't come through to be a rheumatologist until I was doing my residency. I was just doing an elective in rheumatology, and I just enjoyed it. I just enjoyed the way that patients, the interactions between physician and doctor. It's such a close-knit kind of an interaction.
It really is, and I have many doctors because of the illness that I have. You know, diagnosed Sjogren's syndrome and connective tissue disease. But for some reason, our relationship is very different than the others. And that is one of trust that I think is the basic necessity for any patient to have with their doctor. You have to trust your doctor in order to move forward. I was sharing a story before you got here about my refusal to use the cane. I don't know if you remember that.
I remember this story. Actually, you had just come from Beth Israel.
Correct.
You came from Beth Israel. I think you were having some really unrelated chest pain, nothing came out of that. But you came to the office looking really sluggish, and you know, you're like, I'm not going to use this cane. I mean, you could hardly walk.
I could not walk.
You could hardly walk.
I could not.
No, she says, I'm not going to use the cane.
No.
You know, I said, okay, now I've got a problem in my hand. I have to get her walking, and I have to find a way to get her to walk.
Well, and I shared that I fell a few times, we know this, because I refused to use the cane. What I want to know from you is, in that sort of situation, because I think I'm a model patient now. I would not say that I was a model patient then. What is it that you do as a doctor? How do you deal with people that come into your office who refuse to follow your advice? I mean, they're there to get advice, but then they take your advice and disregard it.
You know, that is actually the average patient. So we've learned over the years, and we learn to cope with this. Caring for patients is a very precious thing, and I remember one patient stated it so eloquently. She gave me a Bible, in which out of the things she wrote, one thing came out of that whole paragraph. She says, I have been assigned under your care by a greater power. I have been assigned. And that word, you know, I'll never forget it. You know, I'm thinking patients are assigned. It's an assignment to care for this particular person. This is not someone who just comes in and goes. Whether this person comes in for day one and leaves for various reasons, or whether this person stays for years, for many years, this is an assignment that needs to be fulfilled.
Well, you take your assignments very seriously. You know, this is a lady, ladies and gentlemen, who shows up at the hospital when you're in the hospital. She calls you when you're home, okay? She does home visits, okay? Now, this within itself in this day and age is an unheard of thing. But I'm sure that, you know, we've had talks about her overworking, because I told her that she needs to be here for us, and if she's overworked, then what will we do if she's sick? So, you know, there's also a need for you to maybe pace yourself a little bit.
And I have begun doing that.
Very good. Very good.
Just begun.
So what would some of the other things be that you think make a very good patient-doctor relationship? I said trust, because, you know, I feel that trust is number one. If I do not trust you as a doctor, then basically everything else goes out the window. That's just how I feel. What else would you say would be very important to the doctor-patient relationship? In any kind of relationship, one of the things that must be there, and you are right, that is the cornerstone. Trust must be there. Besides trust, there has to be reliability. There has to be integrity. And you know, the word integrity itself, we use it loosely, but that means doing the right thing even when no one is looking. Exactly. Give me an example of what you mean with your patients. I'd like you to give me an example of a patient with no integrity, let's say. How does that patient behave?
How does that patient behave? This is the kind of a patient who you prescribe a medication, and as a physician, I'm all excited. I know this medication is going to make this patient better. This patient, I'm expecting, I have great hope. And then the patient comes back. I see that the bottle is still 3/4 full 6 weeks later. No refills has been made. It really crushes your heart, and you feel that the patient still complains of the same symptoms.
I see. So again, they come to you to help them for something, and you know, I'm guilty of this as well, okay? They come to you to help them for something. You have the answer to help them, but they do not do what you tell them. And do they say they're taking the medicine? Is that where that's okay. So they claim to be...
At times, some patients would admit, first thing they would say, doctor, I still have the same symptoms, but I have not taken the medications. Others would hope that the questions will not be asked, but obviously I will ask. Have you tried the medication? When did you last take the medication?
Right.
That's the way, because when you ask them that question, when was the medication last taken, that's where it usually starts trailing off. Well, was it last week? Well, actually yesterday.
Right.
Then you know something is wrong.
Okay, so then that then leads to other problems as well. So you're mentioning the integrity. What about patients who, for me, I found that with other doctors, that they're not willing to listen to anything that I have to say. And I think that's another thing that makes our relationship unique, in that we learn from each other. So if I said, well, I tried this and it helped me, you say, oh, really? Did I see you right?
Oh, yes,
you know,
I've
right?
documented the little things, the oils you've used on the skin, you know, all these other things, the herbal teas.
And very often you will say to me, you know, a patient told me this helped them, you know, maybe this will help you. And I go and I try it. But there are so many people who are not willing to hear that.
You know, a doctor's-patient relationship is a dynamic one. You know, the patient grows, the doctor grows. The patient comes, and we learn from our patients on a daily basis. You know, because there are some symptoms that are atypical. We do not expect in a particular illness. And then this particular patient has it. So that teaches us something else, something new that is not in the textbook that the patient has taught us. So patients teach us on a regular basis. And that's how doctors in training, residents learn, really.
Well,
by what patients tell them, the history that the patient relates to them, the history of their illness.
Well, you know, that's the way it should go. But, you know, I had been sick for many years, and no one could tell me what was going on. You know, I would go to the doctor, I would say, I feel this, I feel that, I feel this, I feel that, and they would look at me and say, but you look fine. Yeah, you have a, you know, because I try to have a positive attitude most times. They would say, see that and say, and then it took someone to run one test. I come to you, I tell you these things, you run one test, and I find out what's going on. You know, but we'll talk more about those things later when we're joined with the other members of our panel. We're going to be joined by Ms. Tayumika Zurita from the SLE Lupus Foundation. We'll be joined by Ms. Catherine Soto from the Arthritis Foundation. And we're going to talk a little bit more in depth about symptoms and diagnosis and how to receive treatment. And Dr. Pervil is going to be there to assist us with our medical questions. So if you stay tuned, we'll be right back. We're sitting here today with Tayumika Zurita from the SLE Lupus Foundation. We have Ms. Catherine Soto with the Arthritis Foundation. And you've all had the opportunity to meet Dr. Mona Pervil, rheumatologist and my good doctor, right? So we're going to talk, my friend, yes. So we're going to talk about rheumatological disorders, and we're going to start by talking about symptoms. And the reason that we're starting here is because that's where it all begins. You start to feel things that don't feel quite right, and you're not sure exactly what's going on. I personally had about 5 years of these symptoms before I received the diagnosis, and I had several things to go wrong in a major way before I was even able to get to the right doctor to tell me what was going on. So although there are many diseases that fall into this category, they have many different symptoms that overlap. And so that's why we're starting here. So if you're at home watching and you have things going on, not to alarm you, but to just make you aware of some of the things that your doctor should be looking for when in fact they might not be looking, as was my situation. Okay, so my diagnosis with Sjogren's syndrome and undifferentiated connective tissue disease took 5 to 6 years. It started with, you know, just pain that I was having in my joint, my thumb joint. It would get stuck sometimes, and I would just kind of push it back in place and keep going. And, you know, then it would spread to other joints. And finally, I would start going to the doctor to pursue trying to find out what it is that was going on. And I'd say, you know, I feel pain here, I feel pain there. And the doctor would say, oh, you know, you're getting older, you're in your 30s, things happen, your body changes when you get older. And then it progressed as time went on. I started getting blotches of hair that were coming out. You know, I went to this doctor, I swear to you, and my husband can attest to this. I went to him 5, 6 times about the hair falling out. And he would say, he would give me this little lotion to put there on the thing. He never did anything but that. He'd give it to me, and that was it. And I was tired and everything. So my question is, you know, is this a common occurrence? You know, what makes it so difficult for doctors to recognize the symptoms of these autoimmune diseases and then, you know, perform the necessary testing and so forth to achieve a diagnosis?
Well, good observation. Well, Joanna, one thing you need to consider is that in this type of society we live in, physicians are under a whole lot of pressure. Pressure to create, pressure to make, pressure to produce, and patients are our responsibilities. What do? First of all, a general practitioner has so much they need to learn, they need to be aware of. And because of this, the pressure to do so many things all at once, and they're not really equipped, to take care of every single subspecialty. So this is the reason why they normally refer patients to rheumatologists. So now the government, the federal government is having programs in place so that the general practitioner will know exactly when it is an urgency to really send a patient to a particular specialist, such as in your case, someone who comes in with symptoms the doctor cannot understand, clearly should be sent to other specialists. And I think this is what doctors have been trained more now than ever to really learn when is the proper time to really refer a patient.
Tayumika, for me, emotionally, it really wore me down because I knew that something was going on. So, for me to keep going to the doctor and having the doctor say, no, there's nothing going on, was disheartening to me because it made me start to feel that maybe something was wrong with me. You start to then internalize that and think that something's going on with you. Is this something that you've encountered with other patients that come to the foundation?
Right. Typically for lupus, since the symptoms they mimic the symptoms of other diseases, so a lot of times you have patients who are being misdiagnosed. It is estimated that in the U.S. there's 1.5 million people with lupus and 60,000 in New York City. But similarly to what was mentioned, I do believe that the number is a lot higher because a lot of patients are being misdiagnosed, and then you also have a lot of patients who are walking around and they don't know what's wrong. With lupus, I had this one patient who she was told she had pneumonia 9 times, and it took her about 7 years before they finally found out that it was lupus. And like I mentioned earlier, the key to lupus is there's no prevention, so the key is early diagnosis and proper treatment. So when these patients are diagnosed at later stages, then the disease is already progressing, it's affecting the kidneys, it's affecting a lot of other organs. And lupus is a major cause of premature cardiovascular disease, kidney disease, and stroke in young women. So early diagnosis is key to properly managing a disease like lupus. So
I would then, I think, if I may, encourage people to just be persistent. If in fact you are, feeling some things and you go to your doctor and you're not really feeling that you are getting the results or the treatment that you just, be persistent, keep going. And I'm speaking from a personal perspective. It is difficult to do that because you think the medical professional knows better, they are skilled in this area. So when you go to that person and you're told, no, I don't find anything, you really start to wonder if there's something going on with you. But pick yourself back up and go back and be persistent. Fatigue.
Yes, fatigue. Fatigue is not uncommon in any inflammatory problem, disorders, anything that is inflammatory in nature. There will be morning stiffness. There'll be fatigue and morning stiffness. It's one of the first red flag that will tell us something is wrong. So, like for me, fatigue does not mean that you didn't get a good night's sleep. This is not what that sort of fatigue, what this is. It's a feeling as if that you can't even raise your foot to make a step. It's, literally you're extending all the energy you have just to put your hand up. It's not just, I want to make sure that people understand that. It's not just being tired. It's a draining feeling that you just cannot shake. No matter what you do, no matter how much sleep you get, no matter how much rest you get, you wake up in the morning fatigued. So based on this symptom, the people who come to the SLE Lupus Foundation who are experiencing this particular symptom, how does that affect them in terms of maintaining their daily lifestyle and just, trying to maintain a positive outlook under those conditions?
Right, that's a great question. With a lot of the patients that I see, they're young females. Lupus is a minority women's issue, it's a public health issue, it's a research issue. So with a lot of these females that come into the office, they're devastated. They feel like the doctor has handed them a death sentence. And unlike Dr. Pervil, she's a great doctor, and we've been working since I started working at the foundation. A lot of the doctors are not sensitive. They just tell them, well, you have lupus, and a lot of the times these females don't really know what lupus is. So they come to the office crying, they're depressed, they feel like they can't go on. A lot of them, if they're getting ready to go to college or start their careers, they feel like, what am I gonna do now? So what we do is we try to tell them that you may have lupus, but lupus doesn't have you. We try to teach them, control what you can, and the things that you can't control, just try to manage it. Do the best that you can, because I do believe that it starts in your mind. And a lot of the patients, it's really hard because in their mind they already feel, I'm gonna die. I've never heard of this disease, and then the doctors are not sympathetic, and they just tell them, well, this is what you have to do, these are the medications that you have to take. So it takes a toll on them emotionally. So it's a lot of work to get them to know, okay, you have lupus, but you can still live on. You may not be able to do all the things that you used to, but it doesn't mean that you have to stop everything. Like one of my patients, she thought she was coming to the support group to learn how to die. And she actually said, when I came here, I came to learn how to live. And every time I come here, I make great friends, and it motivates me just to keep going from day to day to day.
Where do you think that comes from, that lupus is a death sentence? Because I've heard people say that they think that they're automatically not going to live past 35.
Right.
Where did that come from? This whole myth. It's a big myth that's out there that I've heard people say quite often.
I think there are a lot of misconceptions about what lupus is. I've been to so many health fairs, and sometimes when people just look at the table and they see lupus, they're like, oh, I don't want any of your information, as if getting the brochure is going to give them lupus. But it's just like, the misconception. Some people think that, oh, is that a cancer? Is that like AIDS? Is that this? Like a whole bunch of things that you'll be surprised. And I think it comes from that. And then also the fact that there's the SLE Lupus Foundation, one of our main goals is to increase awareness, public awareness. And a lot of people, you hear a lot about diabetes, a lot about cancer, a lot about a whole bunch of other diseases, but you don't hear that much about lupus. So we're trying to change that, and we have been increasing the public awareness so that people know, okay, lupus affects a lot of people, and it's not a death sentence. It's a chronic autoimmune disease that if it's not managed properly, you can't die from it. And the issue is that in public health, the key is prevention, prevention, prevention. When in lupus, there's no prevention, so that's why public awareness and spreading the word is extremely important.
Well, that's what we're here to do today. We're going to spread the word. Let me ask you a question, Catherine. So arthritis, people's reaction to that is, oh, you have arthritis. Like, it's such a common ailment that people have. I think I would like people to understand that are watching the magnitude of arthritis and how many people are affected by arthritis and the different varied levels of that. If you wouldn't mind, telling the people about that.
Arthritis is kind of an umbrella term. It covers, a lot of people don't know, but there are over 100 different types of arthritis, and a lot of times people associate arthritis being an older person's disease, if you will. But the truth of the matter is, we hear lupus and how many, there are young women who are affected, and juvenile arthritis is a disease that affects even people, young children who are born with it. So there's a lot to that umbrella. There's a lot under there, and so that is a misconception. And while some types of arthritis, like osteoarthritis, are types that you can help prevent and avoid progression of the disease, certain types like lupus and rheumatoid arthritis will come, and you just have to find ways to manage the disease and control it, educating yourself. So the magnitude of arthritis, 50 million Americans have arthritis.
Wow.
In our region, meaning New York, New Jersey, and eastern Pennsylvania, there are about 7.2 million people with arthritis. And in New York alone, 3.7. So it's a disease that's very widespread, and we want to address it. And so it's important to build that awareness.
Let's talk a little bit about juvenile arthritis, because it is something that is a growing problem. and you talked about the children who are born with. So what are the symptoms that a mother comes to the doctor, and Dr. Pervil, you can then chime in on this. What are the symptoms that a mother comes to you and say, okay, I think something is going on? What is the first red flag, I think, for children?
It's interesting because a lot of the parents we've talked to have expressed that it has taken so long, sometimes up to a whole year, before they can get an actual diagnosis, because a lot of children, as you imagine, are involved in sports activities. You know, you fall and you may have some swelling. The child may have some swelling, and it may not cross the parent's mind to think that this is a chronic issue. But a lot of times when it's prolonged and there's more severe, widespread swelling, that's when a few red flags come to the parents. And a lot of times parents' first approach is a primary care physician who might not necessarily have those tools readily available to assess that. And then but with working closely with their physician, are able to then be referred to a specialist that can, a pediatric rheumatologist that can do the appropriate testing that can identify this as a diagnosis of JA.
Okay, so Dr. Pervil, what would the testing be? What is the testing that, because again, this is a repeated, I mentioned this, you mentioned this, you mentioned it. We're going to doctors who are not prepared for some reason on the primary level. They're not prepared to recognize what sort of tests that need to be run to diagnose these things. What is it that if I'm at home who is feeling something and have been feeling something and their doctor is not doing it, what are some of the things that I can recommend gently to my physician to look for?
First of all, when a child develops rheumatoid arthritis, as Catherine just mentioned, usually it takes a while for the patient, for the parent to really know. And the most common presentation would be a limping child. The child limps. The child starts limping, and it may not be recognized. This child could have fallen the day before, and you know, the X-rays are done, they're taken, and nothing is wrong. Blood work is done, and nothing is wrong. And to make matters worse, it is not like the typical adult with rheumatoid arthritis, where you can get a blood test, which is called the rheumatoid factor, and that can be positive, because you have various subtypes of juvenile rheumatoid arthritis. Now, the new nomenclature actually is juvenile JIA, which stands for juvenile idiopathic arthritis. And idiopathic is something that we do not know about the etiology. We don't know why it occurs. And these children, when they come in, the tests are negative, X-rays are negative. Wow. All you have is a child who complains of pain in a particular joint. And it does take time. And that's the problem. And to make things even worse, one of the subtypes can actually lead to blindness if not recognized early. So parents who think their children may have rheumatoid, the child immediately needs to be taken to an ophthalmologist, not an optometrist, who really, this is the professional who prescribes eyeglasses for vision, just for clarity. For visions, they determine what is your vision, and then from there, decide what type of glasses to prescribe. But the ophthalmologist is the person who actually looks inside the eye and can see if there's any abnormality that occurs. So juvenile rheumatoid arthritis is very, very, very delicate. It's a very delicate presentation.
Wow. How many children are we talking about now?
In the United States, 300,000 children, and we believe that that's definitely an underestimate. And the sad part is that there are many states that don't have a pediatric rheumatologist. So you can imagine someone in the Midwest who has to go to another completely other state to find care for their child. In New York, we're lucky. We're very fortunate because our city has some great research and some great specialists, but it's a widespread problem.
Wow. So that's a lot. I really had no idea that the juvenile arthritis had, first of all, so many different strains of it. How many are we talking? You said 100? Over 100?
Well, there are over 100 different types of arthritis. And as Dr. Pervil mentioned, we're talking an umbrella of juvenile idiopathic arthritis because the origin is not really known, the source of it. But there's juvenile rheumatoid arthritis. There's what we call juvenile dermatomyositis, which affects mostly the muscles. They feel pain in the muscles. So there are different types, and there are what they call oligoarthritis, affects multiple joints of the body. So it's something that is categorized under many different diseases. Psoriatic arthritis in children also exists.
That's also the case with lupus, is it not, that there are different forms or different types of lupus?
Yeah, the two main forms are systemic lupus erythematosus, SLE, and also discoid or cutaneous lupus. Discoid usually affects the skin, so you have rashes, also alopecia, your hair can be falling out, and then systemic lupus. Lupus is very individualized, and it can also affect any organ of the body. So no two cases are alike.
And one, if you have the rashes, does that mean that you have the other? Or they are separate? It can be,
Yeah, usually a patient that has discoid lupus, like 90% of them, they'll just always have discoid lupus. And then 10% is mentioned that it could turn into systemic lupus where it starts affecting other organs of the body.
Okay. Let me ask another question, Dr. Pervil. So, is it a common occurrence that, let's take my situation for example. A patient comes in and you test them for certain things, and you come back and you test them 3 months later, you see nothing. Okay? The patient comes back, they may have a different antibody present or not one that was there before. What causes that to happen? I mean, that has been the situation with my case, and that sometimes this is there, sometimes it's not, sometimes something else is there, sometimes it's not.
You know, as physicians, we usually try not to chase the autoantibodies. We call them autoantibodies because if we're talking about connective tissue disease, one thing we need to understand is an autoimmune disease means that the body fails to recognize self. It feels that there is an unknown antigen or a foreign body attacking itself, attacking the body, that is. So the body starts creating autoantibody because there's really nothing there. You don't really have an invader. There's no bacteria, there's no infection, there's nothing, a source. So what happens is that the antibody that the person makes destroy their own organ. So this is, you know, at a glimpse, this is what an autoimmune disease is. You know, so what happens is that the body at various states, let's say someone is in a state of stress, and great stress for psoriasis. Let's take psoriasis as an example, which is an autoimmune disease. It has been, we know that it's well documented that people under great emotional stress that can trigger an acute flare of their psoriasis. Therefore, the autoantibodies may be high at that time. And in lupus patients as well. So there are certain autoantibodies we do once, we never do again, because they go up and down and up and down. Except if we are looking for a diagnosis we haven't yet identified. And you have to understand we also have overlap, meaning you may have one particular autoimmune problem, let's say lupus, and then the person develop rheumatoid. And it's not uncommon to see someone even develop a third, dermatomyositis. You know, so you may have one, so sometimes we have no choice but to really keep on testing according to the patient's symptoms, because other autoimmune processes, it becomes easier to develop a second autoimmune process. Just like Sjogren, you can have primary or secondary. If you have the primary, that means the person develops it the first time. Secondary would mean they already have another autoimmune problem, and then they develop Sjogren.
So once you have tested positive once, we know that you have the tendency to carry this disease. Is that the correct assumption to make?
Yes, that is if we're talking about the ANA.
The ANA, correct.
Which is the autoantibody nuclear antibody. This is when the person makes antibody against its nuclear cells. So that tells you something is wrong with the immune system, nothing else. Or something may not be wrong with the immune system. It could be a false positive test, which can create a problem because certain medications can cause a positive ANA. So now if you have a positive or false positive test, sometimes for whatever the reason, we create, a physician decides or clinician decides to get an ANA testing, and that comes out positive. The patient becomes all frightened, gets to Tayumika, and they don't know what to do. They're desperate, or sometimes they would call the office. They want to make an appointment. I have to see you fast. I have lupus. And really, it's a false positive test. I'm not saying, I just wish every time, in every case it was. It's not always a false positive, but in cases it can be a false positive test.
Wow. So let me ask this question, because we were talking about this earlier. When a person has an illness such as arthritis or lupus, and to the naked eye, the person may appear to be fine. Okay, this is something this is part of the reason why we're doing this, is because we all believe that this may be part of the reason why things are not diagnosed. You go to your doctor, you may appear to be fine, and the doctor does not necessarily follow up on things. How do you find in your experience that this has emotionally impacted the people that you see that come into your office? The fact that they look fine, they appear to be fine, but they know inside that they're not feeling well.
Right. Like I mentioned earlier, it's very devastating. It causes them to, an emotional stress. And I have an example of a patient who was in her 20s, and because of the prednisone, which is one of the medication that doctors prescribe, rheumatologists prescribe to lupus patients, she's had to have 2 knee replacements and 2 hip replacements. She's only in her mid-20s, and because of that, she can't really take like public transportation because of the stairs and the train, and then even the buses. So she has accessoride. And when she gets on, there's not one time that someone mentions to her, "What are you doing here? You shouldn't be on this. This is for like older people, like seniors." And then every time she has to explain, "Oh, I have lupus." And it's tiring because it's like everyone says, "You look fine." And then another issue that we found out is also like with family members. A lot of times they don't believe. They think the patient is being lazy, or you don't want to do your chores, you're in bed all day, nothing is wrong with you, you look fine. So, they get angry, and then they get like bitter, and they're resentful, and then they don't really want to talk to nobody because it's like, why should I talk if you don't really understand? And then this is when our support groups are extremely helpful, because they can come and see other people that have similar symptoms, and then they tell themselves, "Oh, I'm really not crazy." And then also we have support groups where we have the family and the friends that they can come, and then when they hear other people sharing the same things that their family members experiencing, then they know, oh, she's really sick. And it's really sad that if you tell your family member, "This is how I'm feeling," that not all, but like a lot of them don't believe you because you look fine, you look normal. They have patients who they can't even walk 2 blocks without they're getting out of breath. And they're fine, they're young, and this is what what the disease does, and it messes with your self-esteem. It messes with your ability to, to think high of yourself and say, okay, I have the disease, but it's really preventing me from doing certain things. And then it's constantly, you have to explain to people, well, I have lupus, and that shouldn't have to be the case.
I just stopped explaining it. And I totally relate to that. I stopped explaining it. As of late, I've met people that I felt more comfortable with saying that I had Sjogren's syndrome, or I have undifferentiated connective tissue disease, but I also felt like I had to prove myself before I would say that. I had to demonstrate that I was in fact just like everyone else before I felt comfortable enough to say it. So I think that the fact that we're speaking about this is very important, and I hope that people will start to talk more about it. Then maybe we can dispel a lot of these myths that are going around. What about you with the, patients with arthritis? Do you find the same situation?
Absolutely. To echo a lot of what Tayumika has said, one other thing I find is judgment. They feel that they're especially young adults. In what I've seen, young adults are, out there, they look fine, they're working, they're doing their thing, but they are going through this internal struggle, and they feel that they're being judged at work or, in their social lives, in their relationships. They don't know how to approach certain topics and the specific medical needs that they have. And, there's one couple that is near and dear to my heart. One in the couple does not have arthritis, and the other one has a very severe form of arthritis and needs someone to do the injections and needs someone to pick them up when they fall, if they've ever fallen coming out of the shower. So it's like a longing for a relationship and someone to understand what their experience, what it's like to go through their experience. Having to, as you said, constantly prove yourself. It's a big pressure on a person. So just to echo a lot of what's already been mentioned here.
I think it's unfortunate, but it is, it's the sad truth that once you have a label of any kind, and once you put that label on you, people look at you differently and treat you differently, and you don't necessarily want that. You would prefer to just be treated as you would treat anyone else. Okay, so now let's say that you have your diagnosis and you haven't found Tayumika yet or Catherine yet. You're just a new person. You've just gotten a diagnosis. What would be the first thing that you recommend that a person does?
Well, I always say once you have a diagnosis from your physician, making sure that you are educated about it. Nurses are a great resource because they really are so involved in your care. They're part of that team. So talking to your healthcare provider, having a deeper conversation about it, but also looking for resources. A lot of people start online, and now there's a lot of information on the website. So just making sure that you're going to reliable sources, but contacting the SLE Lupus Foundation, the Arthritis Foundation, other organizations that focus on these specific diseases is a great start to get educated.
Once a patient becomes diagnosed, the important thing is that they become very, very knowledgeable about the disease. And the team, we need to have a team approach. Any physician, we have to have a team. And the team is a good nurse. We also need to have a physical therapist, because many of these people would need some type of physical therapy, especially fibromyalgia patients. We need to have an occupational therapist. You may need a social worker for all the issues that Tayumika mentioned. So really a team approach, we need to create a team once someone becomes diagnosed. And educate the patient. I agree. You do not have to tell everyone I have lupus. You do not have to tell everyone I have rheumatoid arthritis, because these illnesses are just the same as having diabetes and hypertension. I haven't seen one person go and advertise that they have high blood pressure or diabetes. We have about the same number. We have about 50 million of people with arthritis that you just stated. And we have an equal number of people with diabetes and high blood pressure. Those are very, very similar in a horizontal line. No one goes around saying I have blood pressure and diabetes. So the patients need to be educated. The patient needs to know they need to take care of themselves. They need to have a proper nutrition. Nutrition is key in any disease process that you speak of. Now, no matter how many medications I give to a patient, I may give you 10 different types of medications. But if you are not well nourished, your cells are weak, and you have a potentially disabling disease, that is a call for disaster. So nutrition is key.
In general, we're talking generally, an important thing is a balanced diet, healthy balanced diet. But in my case, depending on the type of arthritis, some people feel that having a diet that's heavy on antioxidants can help with their anti-inflammatory diseases, and that's taking more of a holistic approach. And absolutely, eating blueberries is good for you no matter what you have. So keeping a healthy, balanced diet, tackling the obesity problem is going to be kind of hand in hand.
And also there is this saying that autoimmune diseases, you cannot eat the same type of foods all the time. That's a trigger point for worsening disease. You cannot eat this because you don't know what's really triggering. We don't know what triggers certain diseases. And some people, it could be onions, and others, it could be this. I mean, if I'm eating onions 5 times a day, and that is my triggering factor, I don't know this. My cells, the cells in my body, they don't know that onions is the
So foods, eating the same thing,
variety of foods.
Yes, would be the best thing. And if you're not willing to do that and just leave it to people who need and require your assistance, you need to help your doctors help you. And you need to be an active participant in your own health. And so being educated is a good part of that. And you guys have resources available on your various websites that people can get information. Would you please share those with us, please?
Right, so if anyone needs any assistance, they can give us a call at our 800 number, which is 1-800-74-LUPUS. Also, you can find us at lupusny.org or on our Facebook page at facebook.com/lupusny.
The Arthritis Foundation, we have a lot of online resources. Our website is www.arthritis.org/new-York, or just go to arthritis.org and type in New York. Additionally, we have a helpline, and the number for that is 212-984-8730. We also have a lot of great resources for families and children who have JA. We have family days specifically to address these issues, and we have medical experts that will be speaking on these topics. We also have a Young Adult Connect program that connects young adults with arthritis to each other in a comfortable social setting.
Nice.
We also have a parent-to-parent program that connects parent mentors with other parents who are new in this process and are lost, don't know where to go, have questions. It's a way to connect and speak to somebody about it, so as a sort of support. The information for parent-to-parent is P2P at arthritis.org. So P, the number 2P at arthritis.org.
Okay, and Dr. Pervil?
The best way to really reach me would be to look to the rheumatology.org and look under New York, the state of New York, or we do relocate, so I can't guarantee I'll be there forever. But if you know how to spell my name, P as in Peter, ERVIL -ULYSSE. And I do intend to remain a rheumatologist. I do intend to continue to take care of my patients, including patients like Joanna.
Okay.
So if you look under the Rheumatology Foundation, rheumatology.org, you should be able to look at my name.
Okay. Well, I thank you all for joining us today, and I hope that we've reached someone out there that can benefit from this information. And stay tuned to Chronic Visibility for further episodes. We'll be shooting them very shortly, and take care.
Look at me, I'm as helpless as a kitten up a tree, and I feel like I'm clinging.